Hello, Doug Dormer here. This is Consumer Health Informatics, empowering the patient as a consumer. This is Module 2, Lesson 4, the Cures Act of 2016, and we're going to focus on information blocking. I'll tell you up front, I'm going to show you a lot of words, and we're going to try to skim through them because the detail isn't worth it for a general understanding. You'll get that. And that's what I want you to have, is a good general understanding of what the intent is. What is information blocking and to whom does it apply? Information blocking is the practice by an actor, we'll define that in a moment, that is likely to interfere with the access, exchange, or use of electronic health information, except as required by law. If you look at, remember I said that when we started this whole notion of electronic health records in the 1990s, before HIPAA, before the Affordable Care Act and all the legislation beginning in 2004, it was really as a revenue focused kind of a model, a revenue maximization, revenue management kind of a system. And the fact that I, as a provider, have information about you, no, I don't really want to share with you all the detail in there. First, there's liability risk. Second, if you had all that information, you could go to somebody else and bring all the work I've done. And that's not right. I don't want you to be able to take all the work I've done and just give it to another provider for them to critique and review. It did something from an economist's view. It increased the switching cost. It made it more expensive, more difficult for you as the patient or the caregiver to move to a different healthcare provider. And so information blocking says you can't do that. The patient has the right to control their own information. Now, something people don't realize, you don't own your own health information. That's true in 49 of the 50 states. In one state, you have an ownership right to your information. I forget which one it is. It's a New England state. But in 49 states, you don't own it. So if a hospital, a doctor, your clinic, your lab provides information, does tests and gathers information, it's their information about you. They own it. Now, if they give it to you, do you own your information? No, you own a copy of your information. Now, another provider, does that other provider say, here's my information? Do they believe you? I'd better go get it from the other provider, who says, no, I'm not going to share that with you. That's my information. That's the world in which we came. And it's only been since the Cures Act when they said, no, you can't do that. You have to make it available to the patient. That's what information blocking is, prohibiting the information from getting out. And by the way, it's not only providers, it's vendors. Vendors do not want to play nice with each other. They want to say, well, if you want that information, you have to buy my system as a provider. So trying to fit in as a consumer health informatics product and interoperate with those systems, you can see the inherent sort of political, in this case, not political as in government political, but the business political challenges that one would face. So who are the actors? Well, they're healthcare providers, they're health information organizations, which are also known as health information exchanges, those that hold information for multiple providers or systems, and they are HIT vendors, health information technology vendors. What's significant is that when we consider who's not an actor, the consumer isn't, which is why this gets so interesting. You can do whatever you want with your own information. You just you don't own it in terms of the source. And so that's the issue that they're trying to get at. You can do what you want, but you can't control them in the past. And so that's the issue that we're dealing with that is front and center in consumer health informatics. What is the role of the patient with respect to their own information across multiple providers? That's one of the issues. It will not be information blocking for an actor to engage in practices that are reasonable and necessary to prevent harm to a patient or another person, provided certain conditions are met. Okay, the concept is great. Let's skip the detail. It will not be information. That, by the way, is called the preventing harm exception. Then we have the privacy exception. It will not be information blocking if an actor does not fulfill a request to access, exchange, in order to protect an individual's key conditions of the exception. So there are certain exceptions in here. That I'm not going to go into a long detail of it. They're just sufficient to say there are times when they can say, no, we're not going to share it. And there are various legal reasons why we don't want to do it related to privacy, protecting your privacy. There's also a security exception that says we don't have to share the information if doing so would compromise the security of our system or of other people's information, or even your information beyond what it is you have asked for. So we could spend time on it. It's not worth it for this purpose. They're all really logical exceptions to the privacy rule, to the information blocking rule that says you can't prohibit people. These are reasonable exceptions. And again, they speak to the whole notion, I think, of the Cures Act as well thought out refinements of both past legislation and well thought out with respect to new legislation or new regulations that they were promulgating. So that's it for lesson 4. Next up, I'm going to spend a couple of minutes on FHIR, F-H-I-R, and also where we are in implementation of all this stuff today. And before we get to a last few items in lesson 6. Hope to see you on lesson 5 in just a minute.